Welcome to your Healthcare Choice or Chance. This is part two of a show we've done today. And I'm doing it after a hiatus of about a year because what is happening in the hospital industry and the healthcare system is truly egregious. What the hospital system has become is becoming like Wall Street. It's profits, not patients, and I think everyone out there has got to understand what's going on. There are mergers and acquisitions, there are nurses are being laid off, employees are being laid off, while CEOs are making a heck of a lot of money, $2 million and upwards, and closing of hospitals with CEOs are still collecting huge amounts of money. So we talked about the Transparency and Fairness Act in the last show. There's more to the name of the act than I just said, but if you see it, you'll know what I'm talking about. And now I want to talk about the Patient Safety Act, which will give us an idea of what's going on with nurses in Massachusetts and around the country, because nurses are handling a very, very heavy load when they're handling us as patients. And I have back with me my great and good friend, Francis St. Eaton, a retired registered nurse from Quincy Medical Center. He was a critical staff nurse there for many, many years. And he's been 50 years in the mass health industry, playing many, many roles. Sandy has been on the board of the Mass Nurses Association. He represents the Mass Nurses Association on the steering committee of the Labor Campaign for Single Payer. He was the past chairman of the Mass Campaign for Single Payer Healthcare. Sandy has an AB degree from Boston College in philosophy and theology. He writes on so many issues on healthcare, nursing, and other related topics for Labor Notes, The Mass Nurse, The National Nurse, Peaceworks, Revolution, Yankee Radical, and he's the editor of Sea Change Bulletin, which is on the website and very, very important reading, which I highly recommend to you. He writes on nursing, healthcare, and labor activists. Sandy, thanks for being back for part two.
Always a pleasure, Ellen, to be with you.
So glad you're here because
Me too.
There's just so much to talk about, isn't it?
There's too much to talk about.
I was just thinking that.
It's a little time.
And we have just touched the very surface of this because, what can I say, Massachusetts, we didn't say this in the last show, is one of the most expensive healthcare states in the whole United States. Isn't that so?
And therefore of the world.
Therefore of the world. You know, I'm amazed New York isn't more expensive. I'm amazed that it's Massachusetts, I have to say. So anyway, so now we're going to talk about the Patient Safety Act. Let's get right to the point. Why the heck do we need it, Sandy?
Because the freewheeling maximum flexibility for the employer way of doing things hasn't worked. It's extremely dangerous to get into a hospital and to get out without some adverse effect. As a matter of fact, it's over the years, studies have shown that it's been getting progressively worse. But there is a solution. There are ways that, in fact, we have empirical evidence to cut short the risks and to improve things. At the State House a few weeks ago, in Gardner Auditorium, we had a discussion about our Patient Safety Act, and we called in Judy Schindel-Rothschild, an associate professor of nursing at Boston College, to present her latest studies. She and her grad students just finished a 3-year study, a longitudinal study comparing nursing and health outcomes in California, where they have mandated enforceable limits to the number of patients a nurse can be made to take care of at one time, and Massachusetts, where the hospital administrators have what they want, maximum flexibility to staff down and to put their patients at risk in order to pursue what they falsely believe is a better situation for the bottom line. The study showed, among other things, that well, they actually zeroed in on congestive heart failure as one particular thing, and the nursing outcomes, the lessening of the readmission rate for patients who chronically have that issue, and so forth, shows that it is measurably better where there's a guaranteed level of professional nursing care and appropriate levels of support staff in place. We don't have that in Massachusetts. Several places we've been able to negotiate minimum staffing levels in our contracts where we have contracts in some of the majority of hospitals that where the nurses belong to the Massachusetts Nurses Association. But in general, if you have an accident or you fall ill, we want your chances to survive and have the best outcome to be good and to be equal right across the board, wherever you happen to land up. The system is, as I like to put it, dysfunctional, and that's a description of the, we've talked a lot about the financial injustice, communities that have community hospitals and facilities that are the haves and the others that are the have-nots. The impact of that on bedside patient care and survivability is also a have or have-not situation. In 1999, the Institute of Medicine, which is a semi-public authority set up by Congress to advise it on healthcare measures and policy, stated in a study called To Err is Human that up to 98,000 people, patients in our nation's acute care hospitals, die unnecessarily, unexpectedly, inexcusably in our hospitals. Last year, another not-for-profit organization, ProPublica, repeated the study, and it finds that now, from 1999 to now, they are now saying that it's at least 210,000 people die unnecessarily in our nation's hospitals, and it may be as high as 440,000 die unnecessarily. And that's because healthcare has been corporatized. Its finance capital has moved in and is calling the shots, and that's having a cascade effect involving healthcare right across the board. And what we're seeing is a rash of layoffs, cutbacks, closures, and even if through managed care fewer patients are actually admitted to the hospitals, their staffing levels are cut even worse, even more than the lower admission rates. So that nurses, a bedside nurse, may have not only 4 or maybe 5 that we think is on average safe, but could be 6, 7, 8, 9 or more. We've heard these scares.
I spoke to a nurse and I told her that, and she said, Ellen, she's in a nursing home. She says, Ellen, I have 20 patients.
There are different rules that apply. The nursing homes tend to be regulated at the federal level as well. And that's why the M&A board, and I'll use M&A as a shorthand for the Massachusetts Nurses Association in this conversation, the M&A board back in 2001 had a very serious discussion, and we decided to focus our legislation to improve the situation on the acute care hospitals, not because psychiatric facilities, not because chronic care facilities aren't also areas that are in dire need of help, but because that's where we had the base, we had the information, we had the empirical experience of all of our members day in and day out dealing with this. We file literally thousands of unsafe staffing reports with management and with M&A, bedside nurses, every day, every night, documenting when they felt their nursing license was in jeopardy and that their patients' safety and well-being was in jeopardy. I myself, I retired a couple of years ago from the bedside, but I myself have witnessed the escalating scariness, the chaos out of which things go wrong. These are systems problems. These just aren't individual nurses screwing up. That may be a factor some places, but in general, these trends can't be attributed just to the individual faults. There's a systems problem which the industry refuses to acknowledge, and it says that it can do everything itself to make sure things are right. Well, in fact, they're not.
And not only that, Congress is not involved at all. Not when it comes to safe staffing.
There is a bill. It's like everything else. It hasn't come out of committee. It won't be coming out of committee in the foreseeable future. Right. Jan Schakowsky, a Democrat from Chicago, and Barbara Boxer in the Senate.
In California.
They have an omnibus nursing bill that includes mandates that there be an adequate amount of nursing staff present at all times. That's not going anywhere, as we know.
Right,
Single payer at the federal level isn't going anywhere. The most progressive legislation we can think of isn't going anywhere in Washington, and so a lot of this has devolved to the state level. In 1991, the deregulation of hospital finance, Chapter 495, was pushed through by the Senate Chair of the Joint Committee on Health Care.
Which is who? Do you know?
That was Ed Burke
Uh-huh.
from Framingham,
Uh-huh.
who subsequently disappeared and then reemerged in 1995 as the main spokesperson for the Hospital Corporation of America as they were coming into Massachusetts.
Was he a lobbyist for them?
Yeah, I don't know what the payment schedule was.
Right.
But in any event, this deregulation, which sort of went parallel to the Weld-Salucci privatization of healthcare services and other services in Massachusetts, led to devastation, and the nurses reacted and built a statewide movement to try to create safe patient care. And the physicians at the time, and we've had this conversation,
Yes,
Ellen,
yeah.
during the mid-90s, the late 90s, the physicians, primarily through the ad hoc committee to defend healthcare, pushed back, and the culmination of that initiative, which we nurses and many others in healthcare and not in healthcare came together to help on, was question 5 on the ballot in the year 2000. And almost won, but our not-for-profit insurance companies put $5 million into a kitty for around-the-clock attack ads.
And Dr. Bernard Lown was heading
the
ad hoc.
the head of the ad hoc committee. I really have to say, not to spend our time strolling down memory lane, but the thing in the fall of 2000 that embittered me most was a nurse manager from South Shore Hospital putting on scrubs, pretending to be a bedside nurse, saying how damaging serious healthcare reform would be to nursing, which was a lie. Organized nursing in Massachusetts is solidly behind straightening out the mess, and we have a very specific demand, and we've put it in a legislative form, which calls for on a med-surg floor no more than 5 patients per nurse, with the option always, our legislative initiatives have the option to improve the staffing above that as the acuity demands, and that there be an objective acuity standard also that needs to be applied so that nurses may need to have 4, 3, or 2, or even 1-to-1, depending upon how sick the patient is and what their needs are. And we know that's...
Let me ask you, this bill has been in the legislature since 2008. The House either passes it, and then the Senate doesn't, or vice versa. Why is it having so much trouble?
In 2006, we made a major compromise with the Massachusetts Hospital Association and the House leadership, which led us to actually, our original intent was to put the numbers, the ideal limits on patient loads into the bill itself. The compromise we reached in 2006 was to put that, let the Department of Public Health decide that. The Hospital Association left that meeting saying that they were 99% of the way there toward settling the issue then in 2006. They immediately turned around and started attacking us and attacking the concept that there could be any legislated standards for safety for patients. We got through the House, the clock ran out in the Senate, never got acted upon. 2 years later, we have a 2-year legislative cycle. Again, we made it through the House, got to the Senate. We did our homework, and we had a majority of the senators saying they were on our side, would vote with us if it ever came out. And we got Terry Murray, the Senate President, to say that yes, there would be a straight up and down vote. In the middle, in the even years, the clock runs out on on June 31st. That's the end of the formal legislative session. Everybody goes home to get reelected. So nothing controversial is going to be taken up after July 31st in any given even-numbered year because it's an election year. In the first Monday, the Monday of the middle week in July, I forget the exact date, the Globe had an article pointing out that the governor was concerned about a $100 million shortfall in the budget, and that was due to Chapter 58, the Massachusetts Miracle, as I snidely refer to it, the path to allegedly achieve universal health care in Massachusetts. It failed to do that, and that's another conversation for another day.
Right.
And the Hospital Association, the CEO of the Massachusetts Hospital Association, immediately pledged 22, 23, something in that order of magnitude, $1 million to help the governor close that budget gap if and only if the safe staffing bill that had done so well for 2 sessions in a row in the House and was now earmarked to come before the Senate before the session ran out, was killed. By Wednesday, Stan Rosenberg was commissioned to write the text, and by Thursday, and we were in the gallery watching the vote, it was killed. And that was our last serious attempt.
What year was that?
2008. That was our last serious attempt to work with the legislature to move this through. The situation is still there. The situation continues to deteriorate at the bedside. And we have, like I said...
I'd want you to back up for a sec. Talk about a nurse's day in a hospital where she or he...
I'll tell you about one very, like I said, I've been retired a couple of years, but this situation can still happen.
Let's
I worked in a progressive care unit on the night shift, 12-hour night shift at Quincy Medical Center. It was under prior management, in case anybody's watching.
Yeah.
And one particular night, we had a 20-bed step-down unit. We had...
Which is what?
It's a step away from intensive care. They don't need all of the intubation and some of the most sophisticated monitoring, but they are closely monitored because they are more critically ill than would tolerate being stuck with a bevy of 5, 6, 7, or 8 other patients on a medical surgical floor.
Yep.
And they need cup. We always argued that 3 to 1 is is the limit to the number of patients in that kind of unit. More often than not, we're given 8 patients apiece. We had a 20-bed unit. There were 3 of us, senior, experienced PCU nurses on duty that night. We had, each of us had 4 patients. One patient that had been transferred out of the unit on the day shift to our rehab unit back when we had transitional care units. That's been phased out. Was experiencing chest pain that was not being relieved by nitro. That patient needed a higher level of care, certainly than the rehab unit was able to give. So I got the call that we were going to have another patient come back. Well, like I said, each of us already had 4 patients, and each of us had at least one of those patients unstable to one extent or another. And I very honestly said, it is not safe for that patient to come back to this unit. That would mean that would be somebody's 5th patient, and they already have somebody that they have to pay particular attention to because of the instability of the situation. I called the physician, the house physician that was in the moonlighting who was with that patient up in the rehab unit, and I explained the situation, and I said that in my professional opinion, that would not be a safe thing to do, to move that patient back to this unit at this time because of what we are, because the supervisors had nobody, they said, to help us out staffing-wise. And then I waited, and we all rushed around. This was late in the evening, rushed around to finish our bedtime care, 10 p.m. meds. It's about 11:30. I'm finally getting to the bedtime insulin for one of my patients, and I stuck myself with that patient's insulin needle. And that required a whole other thing in the haste. And
so how long did it take to take care of you?
Well, after things settled before morning, I went down to the emergency room. I was checked over by a physician, and I made the decision that it was unlikely the patient was HIV positive.
Oh, my God.
So I elected not to take
So you must have been terrified.
the treatments. That was one of many. I was more terrified of the patient's situation.
Right.
And so I did call and then we never heard anything else. Finally, I called over to the rehab floor, and they said, oh, that patient was put on an ambulance and taken in town to another hospital. We took care of that so that you wouldn't have to worry about that, and I said, fine. First thing in the morning, the unit manager comes on and tries to ree me out for daring to turn a patient away and talk to the doctor and so forth. And I told her that I have a license, I'm licensed by the Commonwealth of Massachusetts to defend the best interests of my patients and all of the patients, and that is higher than any manager or administrator.
Is that
or
manager
hospital.
a nurse also?
Oh yeah,
nurse?
yeah, it was the nurse, yeah. Long gone, long gone. It's ancient history now. And also the occupational health nurse, the infectious disease nurse on the day shift, wrote up a report and sent me a copy. It basically says that I was at fault for inappropriately using the needle or whatever to stick myself with. And we have a very strong occupational health and safety department at the Mass Nurses Association.
Oh, Mass Nurses, yeah.
Yeah, I'm not going to rely on the employer for
Yeah.
this. And we found...
Say that again. You don't rely on the employer for
Not going to
help.
rely on the employer.
You have your
if
union.
You have yes, and if you have malpractice insurance, get your own malpractice insurance. Don't depend on the hospital's attorneys to use their malpractice insurance to defend you if things turn bad.
So
but
let me
we
ask
have a
you something.
union, and yes, we make out unsafe staffing reports, document that in our professional judgment, we're only taking that assignment under protest because we don't think it's safe.
It's not. Now let me ask you: do you actually pay for your insurance, or does the union pay for the insurance?
Right now, in most places, we pay for it itself. It's $100 a year usually, or something on average. It's in the grand scheme of things, it's small. Some places, well, like I say, we're not going to negotiate with the employee. We don't want the employer's name on it because it's our license, not theirs, and they're the ones that are setting situations up that put our nurses' license in jeopardy. So it's a different situation. So I got a study that showed that it's not the caliber of the needle in terms of whether it's retrofitted, not to be a low risk for sticking. The biggest factor to determine whether nurses and other healthcare personnel get stuck with needles or not is the degree of calmness on the unit. Chaos breeds
craziness,
and haste breeds accidents.
Right.
And that's a bigger factor than having retractable needles or whatever. And
let me just say something to you.
And she didn't. I never heard another word from her either.
Let me just say something. Yeah. No, why am I not surprised?
Yeah.
But you know, you listen to all these stories, and you say to yourself, "Where's the common sense?" I mean, do you really need a study to know that chaos brings accidents? I mean, do we really need to spend X amount of dollars?
You need the power to force the employer to do the right thing.
Exactly.
That's what a union is for.
Because really and truly, I'm not a nurse, but I've certainly done other things. And I know when I move very fast and I have to be under stress and whatever, I'm going to have an accident probably.
That's right.
And I'm not a nurse. So, okay, so let's get to, I want to talk about the, not celebration. You were at the State House with your about the Cayman Islands. I want to fit this into the show.
It all sort of ties together.
It all sort of ties together. And
we've had a couple of trips to the State House in the last few weeks, and we're having another one this Wednesday.
Right.
We're filming this and taping the show on
May 19th.
Monday, May 19th, on Wednesday, May 21st. Nurses from all over the state. Our friends and allies like the Massachusetts Senior Action Council and other groups, Jobs with Justice and so forth, will be coming together to have a visible show of support for the Patient Safety Act and the Hospital Profit Transparency and Fairness Act, and lobby our legislators. If they haven't heard from us yet, they will hear from us on Wednesday. And we've done much. To bring the message home to them. We and the Hospital Association packed Gardner Auditorium, the biggest meeting room at the State House, about a month ago, and we presented a lot of hard testimony. We had the chair of the California Senate, who was there when they passed the bill. The Senate President come by.
What's his or her name?
I don't remember his name. He testified that for him the high point of his career in the legislature was being able to vote for safe staffing in California, and he expected his legislative colleagues in Massachusetts to follow through.
Why? I'm laughing with tears in my eyes when he says that. He expects a.
Well,
because you've tried for so long, so now you're going another route. Now you're going another route.
Right. They still have the opportunity, and there are two staffing bills right now. There's the one that reflects the compromise made with the House leadership back in 2006 that has 5-to-1 as the safe limit. Studies show that 4-to-1 is
in a
probably
med-surg department.
Yeah, in a med-surg, and different all the way down to 1-to-1 in intensive care. With a nurse allowed to take a second patient if that nurse feels it's safe to do so. That's the way we have it in our ballot question. When we submitted the ballot question, we went back to what we originally wanted in 2001 before we made that compromise in 2006. That is a 1-to-4 limit on the number of patients a nurse can be made to take care of. And always, like I said, always, we have an acuity factor built in to improve staffing beyond that as the patient's needs demand. And it's up to management to manage and to make sure that there are resources available to have that happen. And
I'm going to interrupt you just for 1 minute.
Yeah.
Because I do want to mention my book before we even forget. I've written my book, Ellen in Medical Land, about my wild and crazy experiences at a Harvard teaching hospital. It's on Kindle, and it's great help. I mean, it will tell you what can happen to you, and believe me, these stories, if they can happen to me, they are horror stories. If they can happen to me, believe me, they can happen to you. But it is not an unhopeful book at all. What it is telling you is that you can get good health care, but you really must be educated about the system. And the last chapter gives you tips on how to get good health care. So if you are interested, and my feeling is you'll enjoy this book, obviously. It's called Ellen in Medical Land. It's on Kindle. And I've also written my show, my one-woman show, based on the book. I'm now looking for a director. And the goal is to bring it ultimately to Lincoln Center in New York. We want to travel all around the country with the show and ultimately come to Lincoln Center. So if you're looking for an adventure, folks, and you love the theater and you're a director, and also interested in healthcare, please get in touch with me. My email is on the credits. But I'd love to meet you and see if we can work together, because this is also a very important project. It's a funny project, it's a comedy, but it's very serious. But we have to get together on this, folks. We just can't let the nurses fight alone. And right now, it seems to me, you are fighting alone. Even though there is a Physicians for a National Health program, you don't hear the doctors too much speaking up, but you hear the nurses. And
our staunchest ally is the Massachusetts Senior Action Council, which is retirees, mostly trade unionists who are retired right across Massachusetts that are always in the trenches with us. Jobs with Justice, which is a labor community coalition, and a few other unions. And we've built a coalition of up to 100 organizations that have signed on to the bills, but there are a few that are actually mobilizing their members right now to be with us. We're collecting signatures now. In order to get on November's ballot, you need to do 2 rounds of signature gathering. Did the first round, 100,000 signatures raw on each of the 2 questions. They passed muster with the Secretary of State as being certified.
Did you deliver to them on a gurney?
Oh yes, yes, we had a great time. We keep going up to the State House, you know.
Tell about the towel. The towel is very important. They did something that is a riot.
I thought you'd never ask.
It's a very serious topic, but they do have a lot of fun doing this.
We delivered a Cayman Island beach towel to each of the legislators, or at least to their aides. A couple of weeks ago.
And there is a
I don't know if you can see this.
Up there.
When you see it, it's, you know,
There's
and of course the aides were glad to see these. I don't know how many aides might have taken them home for themselves.
Go to the beach. But
to go to the beach.
It says it so well.
Told them to go to the Cape and enjoy the Cape
It
Cod
says
this
it
summer.
so well, because here we have nurses who don't have enough help, and we have CEOs who are making more than $2 million a year.
And we put that in the form of a postcard. In case the beach towels never survived the front office and got through to the reps themselves and the senators, we sent each of the legislators the same message, but on, you know, from the postmarked the Cayman Islands, so that they would visibly see what the issues are there in terms of the in terms of what the hospital administrators and CEOs are trying to get away with.
Well, what gets me, Sandy, and we have only 2 minutes, so but what gets me, and folks, I'm sure it gets you too, here are these nurses trying to do a good job. Some of them have up to 8, probably more patients in some of these hospitals. Yeah. And you've got CEOs making $2 to $3 million a year. You've got closings where there are profits in the hospitals. UMass Medical Center has $70 million in profits and closed the med-surg department. So
IV department is gone. Psych in Fitchburg, their satellite hospital up there, is gone.
It's tragic, folks. It's tragic. So what I want to ask you, we have 2 minutes left. What can people out there do? And are there any events coming up that they should know about?
They can certainly talk to your state rep and your state senator about what you want to see in healthcare. You can certainly, if you get this message in time, join us at the State House to help press the message forward. And 3, you can sign the petition if you haven't already. When they come around, folks will be on at your supermarket or wherever, or at your post office for the next few weeks.
So thank you for being with us today. Thank you so much, Sandy.
My pleasure completely.
Take care.